Welcome to the ED Clinics podcast. My name is James Woolidge and I'll be your host for this series where we'll be discussing everything to do with shockwave therapy and men's health conditions. That's everything from erectile dysfunction through to chronic pelvic pain syndrome, Peyronie's disease, hard flaccid syndrome, amongst others. We'll be talking to a host of experts from around the world to shed some light on these complex conditions. And we'll also be talking to patients that have been through treatment journeys themselves, so you can get a greater understanding of how we can help a broad range of people with these conditions. So, without further ado, enjoy this episode. So, thanks, Eve, for joining me on this podcast. And this is the follow-up where we as clinicians talk about our approach to certain conditions that we treat. In the first one, we've just had a good chat with John on the podcast before about his response to shockwave for erectile dysfunction. That's mostly what we see amongst the ED Clinics network is erectile dysfunction, which is why we've done this as the first topic, I guess. So just as a start point, can you just introduce yourself to everyone that's listening, first of all?
Yeah, so my name is Eve, and I've been a physiotherapist for over 25 years, mainly sort of have an MSK background, but in the last sort of 3 to 4 years, I've really started to be involved a lot more with men's health, partly through my experience of obviously using the shockwave therapy, but then also my interest has always been sort of the lower back and pelvis and hip joint. But then there was this group of men that we would see with sort of, symptoms that I didn't quite know how to treat. So there was a sort of interest in trying to work out, how we could best approach those men. So, with ED clinics, we don't just treat, ED, we also treating, other conditions, male pelvic conditions and pain conditions. So for that reason, I've sort of transitioned more from being sort of MSK based to now being far more men's health. I've got 2 clinics. In my Waterlooville clinic in Hampshire, I do a combination of MSK work and, men's health. Whereas in my Reading clinic, I just do men's health. So, and there's been a through awareness, really, there's been more and more demands and more men coming forwards for all sorts of, male pelvic health conditions that obviously we can help them with.
And on touching on that, you're being shy, Eve. You've written a book on the subject, which was what? What was the title?
So it's Shockwave Therapy for Erectile Dysfunction. So it's a book that I wrote because when I first started to do this work, I just could not believe how poorly informed men were. And, also, no disrespect, but I think the medical profession kind of let them down a little bit as well with not really listening to them. So I kept on getting the same questions over and over again. And then also, men seemed to be a bit lost. They were sort of trying to diagnose things getting treatment before they were diagnosed. So what I tried to do in the book is to try and simplify things in putting it in a chronological order from, getting the problem to, being diagnosed to, demonstrating what available treatments are out there, and then also what shockwave therapy can do for them. So, and then what I tried to do within that as well is to answer all the questions that we were getting from them, So the book is not necessarily written for clinicians. This is for men struggling with erectile dysfunction and their partners, because we can't forget about their partners as well, because, often relationships tend to really suffer because of, men having erectile dysfunction. So I would very strongly encourage partners to read the book as well, so they can understand that, this is a medical condition. This is a problem,
I think on that note, one of the reasons why I think it, as you touched upon, some of the medical profession aren't necessarily so good in that area, of course. So there was a magic pill developed in, I think, probably the 80s, which which meant that for most men, they were greatly helped by what's now known, if your GP gives it to you, as sildenafil, which of course the Viagra is the name. But what we end up seeing are people that either don't want to go straight onto that as a choice, or in fact, after 5 or so years, it stops becoming so effective. And then I think because of maybe the lack of research in that area, because it was so effective, that the world has not moved on as quickly as it should have done for that condition. And again, that lack of knowledge, like you say, about the fact that, you know, there's a lot of men that won't understand that it's a vascular condition, that the erection is maintained through increased blood supply, which is how these medications work. They often do find that quite surprising. So, you know, now we know that people are searching for it more, and there's a lot more noise about this, which is useful because men don't want to talk about it, but clearly they are. And we know the traffic we get from ED clinics is increasing year on year by a huge amount. So from you know, John's perspective on the podcast before, I just wanted to get you on just to talk through some of the things that patients we know ask us about, you know, perhaps what is Shockwave, how the Shockwave is supposed to or theorized to work. So can you talk your classic patient, or talk us through a case history? A patient sees you, the first session, how you approach it, and then the Shockwave aspect, if you wouldn't mind.
So, I mean, the way that we all start off is that we do an assessment. So, you know, patient assessment is key, because we need to make sure that the patient is suitable for the treatment that we're offering. This is a process of asking, you know, lots of questions. We also use some standardized questionnaires. We need to get a good understanding of their medical history, their drug history, because really what we're trying to do is to try and you know, establish whether there is a true, you know, vascular or blood flow issue with the particular patient. You know, most patients, so about 80% of men who suffer with erectile dysfunction, you know, have vasculogenic ED. It's only about 10% who suffer with true psychogenic ED. But then, you know, the other thing that we obviously see in most men, despite the fact that it may be vasculogenic in nature, that there's always a bit of performance anxiety associated with that. You know, so we see that as well, and obviously it's part of how we manage it. But I think the drug history, the past medical history, all of that will give us a good understanding of the patient's health, their lifestyle, because I do think that that's kind of where the key is. That's where, you know, often you will find that there is some form of history. Now, we also know that there, you know, any kind of men under the age of 40 who presenting with ED should really be screened for, you know, potential cardiovascular disease. So get, you know, their cholesterol, their blood pressure, all of those basic tests, you know, a proper cardiovascular screen, for the simple reason that there is a state which is sort of subclinical. So men can start to, you know, demonstrate problems with erectile dysfunction, but there's a thought that within 7 to 10 years, you know, these men may develop cardiovascular disease. So, you know, again, our responsibility is to pick up on those things and to make sure you know, that we work in conjunction with a GP, and also, you know, kind of clearly ask them why we want those tests to be done. So they're kind of, you know, getting a little bit into our world, why we think this is so important to do. Obviously, there's other reasons why men can have erectile dysfunction. Obviously, the male hormones are important. So again, getting sort of androgen tests done through blood tests. So I think that's can be a very good you know, point as well, to have that information available. If the person doesn't have that, then, you know, we can either again work with a GP to try and get those tests done, or there's a couple of sort of internet-based companies that we use who do home kits, which, you know, during the COVID pandemic was fantastic, because we could get those home kits, and it gives them a profile of their male hormones, just to make sure that they're not lacking testosterone. So those are all kind of quite key issues. We then use some standardized questionnaires, you know, and these questionnaires kind of help us with categorizing where patients sit. So, is it mild ED, moderate ED, severe ED? Yeah. Now, the reason why that is important is because just like anything in medicine, if you have something which is mild, then you're probably going to respond quite well to the treatment, and also you probably won't need as much treatment. Where obviously, if things are really severe, then you probably need something a bit extra. So in that way, where we will be looking at the comorbidity, so does the patient have diabetes, and all of those kind of things, in order to kind of work out what type of protocol that we would use. And that's often a question we get asked, obviously not so much from men seeking treatment, but more from clinicians, as in, well, what's your protocol?
Yeah.
Well, the problem is that it depends. There
Yeah.
isn't set sort of protocol. We tend to, obviously, from our experience, from the research that's out there, put all that information together and then come to some kind of, through a clinical reasoning process, come to some form of judgment on what protocol we would be using. And that can be as simple as a shockwave therapy, but often we combine it potentially with some supplements, with perhaps some PDE5 inhibitors, with a vacuum pump. So it really all depends where people are to what we would be offering those types of patients.
Yeah.
Now, what obviously, again, a lot of patients ask, well, how does this work? What does it do? Yeah.
Yeah.
So what I normally tend to do is I tend to talk through through the normal mechanism of getting an erection. Yeah. And just to make sure that people actually understand how men get an erection. Yeah. And there's some key issues with obviously getting the input to the endothelial cells, because obviously it's the endothelial cells, which are cells that cover the arterial wall, which will release nitric oxide. We need that nitric oxide in order to relax the smooth muscles of the arteries so they can fill up with blood. Yeah. And that's basically how the blood enters the penis.
Yeah.
Now, often what men don't seem to understand as well is that the outflow is governed by the amount of inflow.
Yeah.
Yeah. So basically, the more blood comes into the penis, the more compression there will be on the outflow, and that will ultimately block the blood from flowing out of the penis, so men can maintain an erection. Yeah. So this is an important thing. So we know that shockwave releases nitric oxide. Yeah. So, but, just like with PDE5 inhibitors, that's quite a sort of slow effect. Now, we know from, cardiology, which is obviously where the first trials that the Israeli guys did was basically based on the fact that, there was evidence to support that we had neoangenesis. And, neoangenesis or neovascularization is the process of creating new vessels or microcirculation through a process of, in shockwave, through a process of cavitation. So, cavitation is a sort of mechanical force that's being placed on tissue, which what you then get from that is a certain amount of re-stimulation and regrowth of small vessels. Now, if you get more vessels and increase the microcirculation, you will increase the total volume of blood. Yeah. And then the only other thing, which is more also to do from our sort of musculoskeletal work, we also know that there are growth factors that are being released. So when we got grotty tendons and all of that, we know that that can help to increase that sort of cell regeneration. Now, again, with men who may not have been having a lot of erections, some of that tissue viability might not be quite there. So what shockwave can do is kind of rejuvenate some of that tissue to make it more viable. So it really just improves the whole state of the vascular system, the penile tissue, and that's really where shockwave is quite different from any other form of treatment.
Yeah. I mean, and of course, for us that know about shockwave in a large medical setting, it would be known as lithotripsy. And, we use Storts, which is probably the most well-known of the shockwave manufacturers, and certainly the one that's responsible for most of the evidence in this area. And, the machines that they produce by Storts, they're used in cardiology for improving heart muscle and the vessels within the heart. It's a known thing. So, it shouldn't be any surprise really that, what happens in a tendon and what happens in your heart can equally happen in your penis. And I tend to use, in ways that I describe it in sort of broad terms of regenerative, effects on the tissues. It's like giving a servicing to those sponges that hold on to the vessels. Any more detail than that, I'd probably forget, and so would the patient, and they're not really concerned. But the other thing, of course, they ask is, not surprisingly, where do you put it? Are you going to treat my penis? Are you going to treat underneath, here, there, everywhere? And does it hurt? So can you just summarize, the mechanics of what we do with the shockwave?
Yes. So typically, a sort of a session of shockwave, I normally take about a half an hour. The actual treatment in itself takes about 20 minutes. Although most men are concerned that it's painful, it's actually not painful. There may be some discomfort, but we are perfectly capable of, reducing it to a setting that a patient can perfectly tolerate. Typically, we tend to do a good couple of thousand of impulses, on the shaft of the penis, and then we also treat the crura. Now, the crura is actually the root of the penis, so we often only obviously appreciate what we can see, but actually the penis sits deep within the pelvis, and obviously we got the arterial supply comes from the pelvis through the root of the penis, which is basically is in the perineal area, which is basically the area between the anus and the penis. So we tend to treat those arteries leading into the penis as well with a number of shocks, a number of impulses. And that area can often be a little bit more sensitive, but again, because we got a lot of experience doing this now, we will always start really low and gradually build it up, and to tolerance really. Most, as I say, most men have tolerated this very, very well. There's basically no known side effects, which is again often what men are concerned about. There's no side effects. You may get a little bit of discoloration of the skin, but that's transient. Sometimes, for a day or so, it might be a bit uncomfortable going for a pee. But apart from that, we haven't really come across any kind of concerning side effects with any of the men that we treat. Typically, we may do one session a week. Sometimes we do 2 sessions a week. I think to a degree that may depend slightly where the patient is located and their time available. But to be honest, I haven't really seen much difference whether I was treating somebody twice a week or once a week. So I think there are no other sort of things that men sort of worry about, is whether they can kind of continue with life as normal afterwards, or whether they can drive, for instance, or anything like that. But it basically is a very, very comfortable treatment. Men can come on their own to the treatment, go home, and can just carry on with life as is.
Okay. The other thing that came up in the podcast of John, that he was so very erudite about describing, his progress through, and the fact that it's, what we try and do, our approach is to be very realistic with patients. And a part of that first triaging of their particular situation, their health status and so forth, by saying, look, I think it's going to need this many sessions. I think we're going to need to add in this strategy and this tactic, and losing weight and so forth, that we give with all of that. But it's this idea that the short-term changes that people may get within treatment changes may be just physiological, which is helpful, nitric oxide and a few other things like that. But what we're really looking for, and of course the patient should be looking for, is that real long-term change about building some realistic expectations that it might be a month or two afterwards, which John talked about, that actually he was continuing to get benefit month, 2 months afterwards. Is that something that you try and get across to your patients when you're seeing them as well, as a sort of, laying a realistic foundation really of their expectations?
That's right, because again, it's one of the sort of main questions we get asked. Well, when are we going to know it's working? Is it session 2? Is it session 3? Yeah. Now, we do have patients who tend to respond very rapidly, but then there's others who don't. And obviously, when men don't respond, then they can get a little bit anxious to the fact that it might not be working. So really, I think, not that dissimilar really to all the MSK stuff that we do, is that what we're saying to patient, or what I say to a patient, is that, that there's a time factor involved, in such that the neovascularization, those vessels, they need time to grow, they need time to develop. And that's really why, even after the treatment, you can get ongoing further progress. And it's not the first person that I've seen after 6 sessions and they go like, well, not quite sure whether this has worked. So what I tend to do is I tend to follow them up about 4 to 6 weeks later, and ask, well, how are things? Have things improved? Can we get some feedback? And then you hear sort of men saying, well, actually, I didn't really think that this wasn't going to work, but now I'm starting to sort of get, perhaps a few more morning erections and things like that. So really sort of starting to see that things are changing. And I think that that's often a little bit what obviously managing the expectation is extremely important, because so for that reason, I sort of say to patients, well, look, it's not going to suddenly, work very, very well for you. You need to look at the subtle things that may change. Like, for instance, especially morning erections tend to be one of the first things that we see, that they becoming more frequent. And this is really nice from sort of our perspective. If that starts to happen during the treatment, then that is a really good indicator that there is an effect from the treatment that we are providing. Now, sometimes what can happen is that there are patients who are kind of a little bit clear cut to how many sessions we would do, but then there's people who kind of sit in the middle somewhere, and that can be quite difficult to sort of be precise to say, well, let's do X amount of treatment and that should be sufficient. So I very, very frequently do 6 sessions, and then we have a break. And a break is an evaluation period for them in order to be able to sort of get a really good view of where they are, because there's no point in doing more treatment if they don't need it. And then at the same time, at least if we've established whether a patient is responding to the treatment and they want to have some more treatment, well, at least we got evidence of its effect already.
It's a nice approach, isn't it? Is there, we touched on, a number of things there regarding mechanisms and how we approach it, and, perhaps how we're different to other. There's a lot, it's becoming on the market now about, shockwave therapy is good for this, and it's certainly becoming a lot more of a popular topic. And the fact that we use storts and so forth. Is there anything else that you can think that we get asked a lot from patients that would be, if they were online now asking us? Is there anything else that you can think of?
I think it's, one of the things obviously that we get asked is effectiveness. How effective is this treatment?
That's a hard one. It's difficult to answer that, isn't it, really?
It is hugely,
because it depends on those things you said at the start.
Exactly.
Everyone's different. If you've got this health, if you've got diabetes and you smoke and you like a drink on a Friday and Saturday night, that makes you entirely different to someone who doesn't do any of those things, but is starting to get a little bit of a mild ED change. It's obvious to say it out loud, isn't it? But I don't blame people for asking, because we are in private practice and we charge. So, so what's your take on it when you sort of give your response to patients?
I think the way to look at, or the way that I'm looking at it, is very much based on what research tells us. And we know that in men who have mild to moderate DD with no comorbidity, so comorbidities is where they have no obesity or no high blood pressure, cholesterol. So, healthy men, then we know that the success rate can be around 70-75%. Yeah. So that's kind of our base. That's where I always start from. And then I'll go through a deductive process depending on what obviously comes with it. Yeah. And obviously whether they, go into the more severe side or not. Yeah. So, and that's the conversation. So it's a conversation to have with a patient. So before they actually engage in treatment, that obviously, first of all their questions are answered. Yeah. And we're not just sort of going through a menu and saying, well, here, look, these are the options, what you want. That's not really the process of clinical reasoning. So I think the idea really is, and I think that's probably where we are different, is that coming at it very much from a medical perspective, from a physio perspective, or an osteopath, or, we're clinicians, we want the best for our patients, but at the same time, we're not a corporate business. We have reputations to keep up. We teach this stuff, you teach, we got to keep our credibility with, not only our patients, but also with our peers, that that we are there really doing our best to select the patients who are most viable to benefit from this treatment. And it's sad, but from time to time, I say to patients, I just don't think this is for you. You're more than welcome to try it, but the chances of success are really, really poor. And unfortunately, what happens a lot is that we see men who just leave, who have just been sticking their hand their head in the sand. Yeah. And if they would have seen us 5 or 10 years earlier, we wouldn't have been able to help them. Yeah. But they wait so long that really, we've gone past almost a point of no return, which is really sad.
Yeah, it is. Okay, I think that's probably most of the things I wanted to cover, and most of the things I think that patients ask us. I can't think of anything else, but so I will wrap this up, and thank you very much for joining us, Eve. We're doing another one soon on chronic pelvic pain, which is one of your expert areas. So I look forward to that. But thanks for joining us tonight. Thank you, Eve. Cheers.
Thanks.
Bye-bye.
Bye.